Welcome, my fellow investigators of the mind. Today, we are on the case of a classic neurological mystery, the misfiring neuron. Our crime scene? Well, it's set deep within the intricate labyrinths of the human brain.
All right, let's get right into it. Our case begins where so many do, with a really perplexing story. A patient comes in and tells you about some kind of transient, bizarre event, a spell. Now, is this a true neurological crime, a seizure? Or is it a mimic, a clever imposter trying to throw us off the scent? This right here is the first, most fundamental question we have to answer. So the game is afoot.
So before we can even begin our investigation, we've got to know what we're looking for. We need to understand the nature of the crime itself. A seizure in elementary terms is just a sudden, uncontrolled electrical disturbance in the brain. Think of it like a flash mob of neurons all firing off at once when they absolutely shouldn't be. This is the event we're hunting for.
Okay, so first order of business, we survey the scene and figure out if a crime has even taken place. You'd be surprised how many other conditions can masquerade as a seizure. A master detective has to learn to tell the difference.
And this right here is our first crucial piece of deduction. Let's meet the chief imposter, syncope. You probably know it as fainting. So how do we tell them apart? Well, a seizure often strikes completely unprovoked, sometimes leaving behind a clue, what we call an aura. Syncope, on the other hand, usually has a trigger, right? And it's often preceded by things like lightheadedness. But here's the real kicker. After the event, a seizure patient is often confused, what we call a post-ictal state. A syncope patient, they recover almost instantly. Getting this right from the get-go prevents a huge misdirection in our investigation. It sets the patient on the correct path right away. Elementary, my dear colleagues. So, once we suspect we're dealing with a true seizure, our most powerful investigative tool comes into play. And you know what? It's not some high-tech scanner. It's the simple art of taking a thorough history. The story I'm telling you holds everything.
It's just like the great detective himself said. The clues are almost always hiding in plain sight. We just have to train ourselves to observe, to listen, and, this is key, to ask the right questions. The details of what happened, as told by the patient and any witnesses, that's our primary evidence. So, what are these crucial lines of inquiry? Well, first, precipitating factors. Was the patient sleep deprived? Did they drink any alcohol? Next, the aura. You can think of this as the perpetrator's calling card, left just moments before the crime. Then, the ictus. What did the event actually look like? Was there stiffening, rhythmic shaking? And finally, and this is so important, the post-ictal state. Was there a period of confusion afterward, kind of like a dazed victim after an assault? All these details are what build our case file.
All right, we've got our eyewitness accounts all logged. Now it's time to bring that evidence back to the lab. Here we get to use our modern forensic tools to look for objective proof, hard evidence of the crime, and clues about who our perpetrator is.
Our first tool is the electroencephalogram, the EEG. The best way to think about this is like dusting for fingerprints. The EEG records all the brain's electrical activity, and sometimes, even between seizures, it can capture the culprit's signature. These abnormal patterns like spike and wave discharges, it's the smoking gun of abnormal brain activity. Next up, we map the crime scene itself using an MRI. Here, we're literally searching for the culprit's lair, any structural problem in the brain that might be causing the seizures. What you're seeing here is a classic finding, hippocampal sclerosis. That's scarring in the temporal lobe, which is a notorious hideout for seizure activity. Think of it like faulty wiring in a building that just keeps short-circuiting. Identifying this gives us a concrete target for our management plan. So, we've gathered the eyewitness reports, we've processed the forensic evidence, and now it's time for the most satisfying part of any investigation, finally identifying our perpetrator from a lineup of the usual suspects.
And here they are, our rogues gallery, based on the official classification. Seizures really fall into three main families. You got focal onset, which start in one specific area, generalized onset, affecting the whole brain at once, and then unknown onset, where the origins are a bit murky. Pinpointing which family our culprit belongs to is absolutely critical for what comes next. So understanding this distinction it's crucial. A focal onset seizure is like a small fire that starts in just one room of a huge mansion. Now it might stay there, or it could spread and engulf the whole house. But a generalized onset seizure, that's like the entire electrical grid of the city shorting out all at once. The scale and the origin are just fundamentally different.
And within these families, of course, we have specific criminals with their own unique MO. The absence seizure, that's the silent pickpocket. It causes a brief lapse of awareness, and it's so often mistaken for simple daydreaming. The myoclonic seizure is like a sudden thug. It delivers a brief, sharp muscle jerk. And then there's the big one, the infamous tonic-clonic seizure. That's the dramatic bank robber, causing a full body convulsion.
But look, identification, that's only half the battle. Now that we know who our culprit is, we have to devise a plan to apprehend them and, just as importantly, prevent them from striking again. This is the art and the science of management.
So what do you do when a seizure is happening right in front of you? You are the first responder. And the protocol is simple, designed to empower you to act decisively. Number 1, stabilize the scene. That means protecting the patient's airway, breathing, and circulation, the ABCs. 2, investigate the cause. A quick check of glucose and vital signs. And 3, for a prolonged seizure, you have to neutralize the immediate threat.
and that's typically done with a fast-acting benzodiazepine.
Now, for long-term prevention, we turn to anti-seizure drugs, and it's so important to understand their purpose. They don't eliminate the underlying problem. They don't cure epilepsy. Instead, think of them as a 24/7 security system for the brain. They raise the threshold for a seizure to even happen, and they keep that culprit under lock and key. And this is definitely not a one-size-fits-all security system. Oh no. The agent must be matched to the culprit. As you can see here, for focal seizures, we might reach for something like lamotrigine. For generalized tonic-clonic, maybe valproic acid. And for those silent little absent seizures, the really specific agent is often ethosuximide. Choosing the right tool for the job is paramount for successful containment. Okay, now we have to talk about the most dangerous scenario of all, status epilepticus. This is what happens when the crime just doesn't stop. A seizure that lasts longer than 5 minutes, or multiple seizures back-to-back without any recovery in between. I want to be clear. This is not a drill. This is a 5-alarm fire in the brain that requires immediate, aggressive intervention to prevent permanent damage. And there you have it. We've journeyed all the way from the first report of a mysterious spell to identifying the specific culprit and even devising a containment plan. You now possess the fundamental deductive framework for approaching this classic neurological case. The tools are in your hands. The powers of observation are yours to hone. So the only question that remains is, what mysteries will you solve next?